Hello, I'm Dr. John Whyte, Chief Medical Officer at WebMD, and welcome to Coronavirus in Context. My guest today is Dr. Eric Topol, a renowned cardiologist, geneticist, researcher, founder of a research institute at Scripps, and Medscape's editor-in-chief. Thanks for joining me, Dr. Topol.
Oh, of course, John. Great to be with you.
I want to talk about some of the recent studies that have come out even in the past day, where we're seeing out of Italy over 99% of deaths, the person had some comorbidity. 75% of them had hypertension, 35% had diabetes, a third had heart disease. Are you surprised that number is so high, 99% of deaths?
Well, I don't know that it really is. First of all, anybody, once you get past age 50, you see a lot of comorbidities. But we also know that there have been some young people who succumbed in Italy. And in fact, there was a White House press conference yesterday finally alerting to the fact that young people are not necessarily spared from COVID infections. The other thing, of course, that comes a week after the memorable Oval Office presentation where young people have full recovery, no problem. So I know you're queuing into the people who are vulnerable, that is the aged, and because they have comorbidities. But some of these comorbidities don't make much sense, like hypertension. There's no good explanation to link high blood pressure. That could be a proxy for just age. The ones that do have some reasonable connection would be things that would impair the immune system. So age, especially advanced age, for example, chronic obstructive pulmonary disease, because we know that the real problem here is that the virus gets into the lower respiratory tract. And once it does that in a vulnerable patient. So I don't know about this 99% number. I mean, it's dreadful. What I do know, John, which is so disconcerting, is that the number of deaths, of course, in Italy now are the #1 in the world, above China, and we don't have a good explanation for that. The fact that we just tossed it onto, oh, well, they were older in Italy and they had comorbidities, it doesn't make much sense, really. There's something else that we don't know yet.
What do you think about the role of cardiovascular disease? American Heart Association has talked about it. It's listed, as a condition that puts you at increased risk. Do you think it's the same for the person who has a stent versus someone who has decreased ejection fraction? What might be the etiology there in your mind?
Yeah, great question. I already mentioned hypertension, which a lot of people lump into cardiovascular disease, but almost everyone, if they live long enough, will have hypertension. So that one, I don't know that really is important. But as you allude to, heart failure, diminished heart function is certainly one that you would connect the dots because, you just are more vulnerable. It isn't clear that just coronary disease that's not obstructive, like you mentioned, a stent or having had a prior bypass operation or open heart, to me, that's not a clear comorbid condition that would set up for this.
Yeah. Now, you've been very involved in your career in post-market surveillance. I interacted with you during my time at the Food and Drug Administration. What about this preliminary data, much of it unreviewed, that we're seeing out of France relating to the use of NSAIDs and the impact that it might have on coronavirus? Is that something we need to start talking to patients about, or is it too early to tell?
Well, it's really interesting, John. There's been these two drug classes that have been put into confusion mode. One is, of course, the ACE inhibitors and angiotensin receptor blockers, and the other are the non-steroidal anti-inflammatories. And what's amazing about both is that it's just chaos because there's no data to support either harm or potential benefit in either.
Yeah.
Now, there was
for the ARBs, they've been saying both. For the ARBs, they've been saying it could be protective.
Yeah. This is a false alarm that, there have been people that say stop taking ACE inhibitors, and now the group in France and backed up to some degree by the WHO has said, oh, well, don't use non-steroidal anti-inflammatory drugs. There are no data that I have seen, and I try to get my arms around it, that would support that. There's theoretical things, just like, today we heard that the chloroquine story, it's theoretical. There's no data to show that chloroquine compared to control truly has a treatment, effective treatment. So we have lots of, we're in a panic state. It's a crisis. and you're getting a lot of things that don't have data or even a basis for making these proclamations.
Well, there's another study out there from China that says if you have blood type A, that you're more at risk of dying if you develop coronavirus, and if you're blood type O, that you're doing better. And this is getting a fair amount of circulation. So how do readers interpret this information when they see it on social media? It's even being reported by some news outlets. We can't change our blood type as we might be able to a medicine. So what do you do?
Good point.
Is it needless worry?
At this point, I think so. First of all, there's been all sorts of studies over the years, decades, where this blood group associates with that blood group. And associations are not cause and effect, and they're frequently spurious. So we just don't know yet. I mean, first of all, that data has not been peer reviewed. Secondly, many of these turn out to be assertions about a link between a blood type and a outcome. It didn't hold up. It didn't get replicated. So these, I think, are suspect because the blood surface antigens, are just not that big of a determinant typically for outcomes, particularly here with the COVID infection. So we'll have to see. It's possible. I'm not ruling it out, but I think we should be a doubting Thomas at this juncture.
Now, you're an active tweeter. You're very active on social media. I follow you and others. And we have all this conversation about bending the curve. And you tweeted a little earlier today about if we don't have protective equipment, we're not going to bend that curve even with social distancing because we won't have enough clinicians to provide care. But others have been talking about on social media, depending upon where we are on that curve, why aren't we seeing ERs being overwhelmed? Why aren't we seeing people, in gurneys outside hospitals? What's your comments on that, where, some people are, especially younger people, are doubting the seriousness of this epidemic, this pandemic?
Let me unpack that because I think you've asked two important questions in the same. Firstly, the issue about the curve. The point I'm trying to make is if we don't take good care of all our doctors and clinicians and healthcare workers, not only will they become infected, they may have not quarantine, but they may get sick and some may even die. So the point is each of those healthcare workers cares for tens of patients.
Right. So
if we don't make this the highest priority, we lose the ability to care for even the non-COVID patients. And let's not forget about them. In the hospital, it's not that we're seeing COVID patients as much as all the other patients.
Sure.
Okay? So if you take them out, and we're going to have a shortage pretty quickly. Now we get to the second question, which is how come, except in specific hot zones, Seattle and New York City, that most everything looks kind of business as normal, if you will. That is, you don't see, but we're at the earliest point of this country's growth curve, this serious hit that we're going to see. And the doubling is every few days. So just roll this out for another 10 days, which is how long it'll take to be like Italy. So it may not be as bad as the Lombardy region, which was hit really severely, but we're going to see a lot more cities, a lot more hotspots, and we're going to see in those particular hospitals and emergency rooms a real problem keeping up. I mean, in Spain yesterday, I communicated with a physician there who had over 50 admissions to the hospital, no less the ones that all came to the emergency room. We're going to, with COVID and Syria, seeing that in select hospitals. It's not sort of even distribution. It's a problem where the outbreak regions, that's the real challenge.
Now, you're a leader in tech. You talk a lot about innovation. What are we not doing now in terms of utilizing some technologies that we need to be doing?
Well, there's two parts to that one. One is
I like multi-part.
We should have tested, millions of Americans by now. We had plenty of advance warning. Not only did we know what was going on in China, but the first patient came to the U.S., was diagnosed in the U.S. January 21st, which is 2 months ago. We haven't done really any testing until just in recent days to any degree. If we had tested at scale, random, and broad-based, not because you're very sick, we could have gotten on top of a lot of this.
Would you have tested non-symptomatic people? Would you have tested community testing?
Absolutely. No.
If we had the ability to do it, right?
We would do as many millions of tests as possible to see where are hot zones going to emerge before they do.
Sure.
And the tests are cheap. They're easy. That's what we were not prepared. So now the other path, which by the way, we should be testing every healthcare worker, because that's part of the protection for them as well as all the patients that they touch, right, and see. Now, the second part of the story is there's a great tool that we can use, which is digital mass surveillance. So most of us have a smart watch of some kind, and that is tens of millions of Americans. Sure. That data, we've already shown the heart rate from that data can be exquisitely helpful for picking up a flu outbreak before it actually happens. We published on that. So things like that. Yesterday, we saw a big report on just using body temperature with a smart thermometer. So digital tracking at scale, hopefully we pick up the outbreak before it happens. Because if we get it at the earliest possible time, we can do very precise isolation and prevent that exponential growth in that community.
Should we be using location services? Should we be tracking people? You don't have any issues of privacy or concern about that?
This would not be the time for privacy concerns. I mean, that's a biggie for me.
Well, that's why I asked you that, yeah.
But right now, we're facing perhaps the worst crisis in public health that we'll ever see in our lifetime. I hope it's the worst, because people that think that this isn't going to get bad in this country just are not really paying close attention to the lessons learned. And it isn't just China, and it isn't just Italy, and it's Spain and many other places. There isn't any exception here. The only one that's positive to some degree is South Korea, because they were all over this and they did mass
testing, 20,000 tests a day.
Good isolation, quarantine, lockdown, if you will, or shutting the free movement of people. So they have contained us, but now even then, John, we're starting to see that pick up again with more cases after they had shown the flattened curve. So we are learning the lessons here about taking this seriously.
What about Japan? Japan had, some cases early on. They haven't necessarily instituted the same mitigation strategies. We're not seeing that many cases right now. Is it because of where they are on the curve, or do you think something else might be going on there?
I can't imagine it's anything beyond that. This is an eventuality that is, as you say, it's delayed. But we started the same day that South Korea did here in the U.S. Within 24 hours, our first case. So we'll have to see. There's a kind of incubation phase where there's enough people that are infected that are transmitting. And of course, we don't know enough about this asymptomatic carrier story. We know it's not uncommon in the young and even in children. But, these are the sort of unknowns. And the Japan story is part of that classification of unknowns. Wait to see what happens.
Yeah. How concerned are you about, we want to get information out there, but it's not necessarily peer reviewed. So we've gone back and forth on how long people can be asymptomatic and infectious. We've had ranges of different numbers about how long the virus can live on surfaces. Is that helping or hurting? We're so early on, and people hear so much different sources. I've joked everyone's an armchair infectious disease doctor, an epidemiologist with no training. So does it help or hurt?
It's kind of good if everyone did convert to become a citizen scientist. That would help, because that means they're tuning into what's going on. The issue about the viability of the virus, whether it's in the air or on different types of surfaces like plastic or steel or copper. There was a nice New England Journal paper that was peer-reviewed that gave us a lot of insight. Like in the air, we're talking about minutes, but on surfaces, could be even 72 hours, particularly plastic, interestingly. But the other part of that is what we don't know is about the shedding story. and a viability. So the virus has to be replication competent. So just because it's sitting somewhere, if you touch it and you don't have, the virus doesn't have the ability to invade cells in your body, to hijack the cells, which is basically its pathogenicity. So these are the things that we don't know. Why would some people shed virus so profoundly, whereas others, they can be infected? You know, that story that was published in The Lancet is amazing to me. You have a couple, severe infection, hospitalized. They had 372 contacts, not a single one of them ever converted positive. So we got a lot.
What's the reason? What do we think?
It may be that they didn't shed. They're infected, but they're non-shedders. And then they got these other asymptomatic people who are shedding. So this is a lot of unknowns. That's why if we all learn as much of the science as it comes on board, and that means, you know, not just the medical community, everybody tunes in, that kind of awareness will be helpful.
What about testing at home? There's been some discussions that people could swab themselves and then we set it outside our door. Is that a safe mechanism of testing, or are we perhaps putting delivery and other folks at risk? What are your thoughts on that?
I think it's safe. There's this next week, there's going to be 2 companies releasing a at-home kit that you can buy for approximately $150. And then, you know, once you get it, then it takes another few days by sending it back in 48 hours. You know, you have to put this swab pretty far up your nose and then in the back of your throat to the point where you gag, and otherwise you might get a false negative.
Mm-hmm.
At any rate, it is a way to get some information in a pathetic situation where testing is still not widely available. But that's significant cost. And also, you know, it's something that we shouldn't have gotten in this situation in the first place, right?
Yeah.
So, yeah, the home kits, you know, there's also in some cities the emergence of these drive-through stations.
Yes.
I actually think that's a better potential solution, because then you save 2 days. You're basically driving through, so you don't wait for the kit to come to your house and then the kit to go back at the central lab. Yeah. And we should be doing those for free.
Except right now, they're only in certain locations right now.
Yeah, I think we should have that in every city, all over the place. I mean, that's still a low cost. You know, here we are, we're sinking trillions of dollars, sending out checks to every American citizen. And these are relatively inexpensive strategies that we're talking about.
The other question I wanted to ask, knowing your knowledge of drug development, people have been talking about the ARBs, the ACE inhibitors, the NSAIDs. We're starting to see some questions about statins and perhaps their role in if you become infected with coronavirus. Any rationale you see in terms of how statins might impact your ability to fight the virus?
Well, there's data on statins in non-COVID. In pneumonia and respiratory distress. And there was a lot of interest in that for a while, because, well, that'll decrease the inflammation just like it decreases inflammation for cardiovascular disease. Then they did a randomized study, and it was a bust. So I think that the chances that statins are going to help here, because we haven't ever seen data, real positive data for statins, is pretty low likelihood. It doesn't seem to harm, so we don't have that out there, use of statins, but its protective or beneficial effect has to be considered suspect at this point.
Other than increased testing, if you could wave your magic wand and make some fundamental change to address COVID-19 and the evolving pandemic, what would you do? Not what we should have done or whatever, but what can we do today?
Yeah, well, I think the number one priority has to be the healthcare workforce. Mm-hmm. We're not giving them the priority that is vital. The reason being is not just the fact that they're important to care for the patients, but if we lose them along the way, in not just their life, but also they're sick or they have to be quarantined, we're not going to ever keep up. We may have a problem keeping up anyway, but we don't have the protective gear. It's just remarkable that this is supposed to be a first world country, and we don't even have gear. And I mean, the fact that that is occurring, the fact that all healthcare workers have not been tested yet, these are systematic evidence that we're not, that's priority one. So it's not magical, it's sensible, but if there was a wand, we should have done that. It's never too late.
And we've been putting online where people can help donate equipment. You've been tweeting about it as well, and I encourage folks to follow you on Twitter. I want to thank you for taking time on what I know is a very busy day, and thank you for really helping us think through some of this emerging data that we need to look at carefully to best figure out how do we address this growing pandemic. Thank you, Dr. Topol.
Thank you, John, and thanks to you and your team for all that you're doing to help our readership and all the people that are on the site. Thank you.
Thank you.